Hi everybody, welcome to today's session of our Young India Intensivist Critical Care webinars. So today we have a topic on antibiotics and very important antibiotics, that is polymyxins. And very nice speaker today we have. You have all appreciated his earlier talk that is on tigecycline and phosphomycin. So he's Dr. Kanishka Davda. Sir is a consultant in infectious disease at Saifi and Jupiter Hospitals, Mumbai. So over to you, sir, to take us through the next 45 minutes or so and educate all of us.
Thank you, sir. Thank you so much. So, with that, I'll start sharing my screen. See, we'll go through the theory and the cases one by one, right? So, this in gram-negative bacteria, there are various levels of resistance, right? So, the most friendly and sensitive bugs are the non-ESBL bugs, means they are sensitive even to our cephalosporins, ceftriaxone. We rarely see them nowadays, but at least in India, but that's the best one to have if you're going to have something. Then is your ESBL, which is extended spectrum beta-lactamase producing gram negatives. So these will be resistant to third generation cephalosporins, and they will be sensitive only to the beta-lactam, beta-lactamase inhibitors and the carbapenems and higher. Right? Now, there is another level which is ESBL plus, in which we lose even the beta-lactam and beta-lactamase inhibitors, like your piperacillin, tazobactam, and ticarcillin, and ceftazidime, tazobactam, and stuff like that. So in them, we have to use carbapenem and nothing else, no, carbapenem and above. And the drugs below it will not work. And finally, we have the dreaded carbapenem-resistant Enterobacteriaceae and the carbapenem-resistant non-lactose fermenters, which are not Enterobacteriaceae. So these are the levels of resistance in gram negatives. So we will not use polymixins for any of these except for the CRE. So there are better choices available for all of the above except for the CRE. So we are going to usually treat we are going to give these polymixins only in the case of CRE, or if there is some special indication in some rare patient. Otherwise, in most of the other cases, the other drugs are preferred and they are more effective and less toxic, right? So then we go to the types of the CRE, right? So carbapenem resistant enteros can have CRE via multiple mechanisms, and the carba resistant non-lactose will definitely have many mechanisms involved, right? So there are two types of mechanisms when we are dealing with CRE. There is enzymatic and non-enzymatic. So in CRE, most common is enzymatic mechanism. So beta-lactamase production, which is carbapenemase type. So we lose the carbapenems, right? Rarely there may be target site alteration like we see in E. coli with PBP3 insert mutations or a loss of outer membrane protein and rarely in the non-lactose fermenting, there can also be efflux pumps, right? So now when it comes to polymixins, if they have come intermediate, they no longer come sensitive as per the CLSI guidelines. There is only an intermediate criteria. There is no longer a susceptible criteria. So if they come susceptible, the polymixins are quite indifferent to the mechanism of the CRE. And they should generally work for all of these types of and varieties of CRE. But since we do have newer drugs now for CRE, few years back we didn't have any other drugs for CRE. Since we have newer drugs for CRE, we many times need to determine what is the exact mechanism or flavor of the CRE, and the treatment will change subtly according to that, right? So these are the broad enzyme categories in the CRE. There is KPC, that is Klebsiella producing carbapenems. There is OXA48 and OXA48 family of enzymes. And then there is the NDM, IMP, and VIM, which are basically metallo-beta-lactamases. So there is slightly different treatment for these. And if there is a target site alteration, again, there is slight difference in the treatment, right? So when the CRE is KPC or OXA, this new drug that we have, Ceftazidime-Avibactam, it can work very well even as a monotherapy, and it is recommended by IDSA guidelines and our Indian CRE guidelines to use ceftazidime with avibactam monotherapy when it is a proven pure OXA or a pure KPC, right? But at only, almost 60% of our isolates, that's been our experience so far in our hospital, 60% of the CREs are having NDM or NDM plus something else. So there can be combination of NDM with OXA, NDM with KPC, that type of thing. So in that case, we have to give aztreonam along with the ceftazidime avibactam. Otherwise, it will not work. And when it comes to non-enzymatic pathways of CRE, where your synergy test comes negative, which means that the combination of ceftazidime, avibactam, and aztreonam will not work, then we are back to our old friends with whom we struggled so many years and continue to struggle, which will be your polymyxins, phosphomycin, tigecycline, and this new kid on the block, Cefepime-Zidobactam. Now, Cefepime-Zidobactam is a new drug, under phase 3 trials abroad and under phase 2 trials in India. And it has been used in about 30 to 35 patients on a compassionate basis where no other drug was available to treat the patient's infection. And so far, that compassionate use data is extremely good. I was one of the people actually. I have used it in one of my patients with a complete permission from the drug controller of India, and it worked well in my patient as well. And so far, the data is very encouraging. So finally, after many decades, we might have some ray of light in this battle against CRE, especially in the carba-resistant Acinetto and Pseudomonas, in whom we are really not having many good drugs which are effective, right? So this is where we place it. This is where we place the polymixins in CRE as well, right? So this is very important, not just knowing about the polymixin, but where it is placed in this map of gram-negative resistance. Where would you want to use it, and where it is to be used ideally, right? So now there are differences in colistin and polymyxin B, but there are commonalities as well. So, colistin and polymyxin B are the two polymyxins that we have for systemic use. And there are one or two other ones which we use for topical and local therapy, which we'll come to later on. So what are the commonalities that make it easier to remember? What are the commonalities between these two? And then we'll go to the differences, right? And there are some cases next, so don't sleep right now. Very interesting cases. Okay. So, firstly, it is a pure gram-negative cover. There is no gram-positive cover and there is no anaerobic cover. So, in many ways, it is much narrower spectrum than our other higher antibiotics like meropenem, tigecycline, right? So, always remember this. If your patient is on polymyxin monotherapy, then you are not on a broad cover and you are not covering these groups, gram-positives and anaerobes. So that will help you if in case the patient deteriorates, then you know that, okay, it might be the bugs which are not being covered, which are coming up. or it will help you to give additional medicines when you are giving polymyxin therapy when the syndrome demands it, right? Both are bactericidal agents. Huh? There is a loading dose which is needed, and there is no dose adjustment of the loading dose in renal failure. This is a very common error. I hope none of you will make this error, right? Loading dose is definitely necessary because onset of action can take almost 48 24 to 36 hours to start working, and the steady state is reached only well after a loading dose. So never forget the loading dose. Give the full loading dose even in patients with acute kidney injury or chronic kidney disease, right? Then the AUC by MIC is the PK/PD parameter correlated with efficacy. Now, you all know that antibiotics basically are of three types when it comes to PK/PD. One is the time spent above MIC, which is most important for beta-lactams. It is the time spent above MIC which is correlated with clinical success, not the high concentration reached. That is why we have to drug the beta-lactams very frequently and to maintain a good level above the MIC. Then the second group is the concentration upon MIC, which we see maximum with the aminoglycosides, right? So in aminoglycosides, it is the height of the graph, which gives the treatment response. So in aminoglycosides, we are trying to give once daily dosing with one single high dose rather than multiple dosing with smaller doses because concentration is important for the effectiveness. And AUC by MIC is kind of like a mixture of the two. You need a good level above for some time, and we need a little bit of height as well in the graph. So AUC by MIC is what is important for polymyxins. Now, this all comes in important in the critically ill patient when you're trying to leverage the PKPD to manage your patient better. Now, both have nephrotoxicity and both have neurotoxicity and both can have neuromuscular toxicity. And there can also be hyperpigmentation of the skin. Now, there are slight subtle differences in these, which we'll come to later. And both have poor penetration in the CNS, poor penetration into meninges, and poor penetration into lung and bone. Right? So at these sites of infection, we often have to supplement the systemic therapy with more of local therapy. Otherwise, the levels achieved are not enough for a good killing. We don't reach the PKPD targets at the site of infection for the drugs to be beneficial, right? Now, monotherapy often leads to resistance, right? Combination therapy in some high-risk patients was associated with survival benefit in some of the trials. It's not that monotherapy should never be used, but in the seriously ill patient and certain high-risk patients, uh, we probably must combine with another agent, either which is synergistic or other which will support, because there will be relatively rapid development of resistance, and you lose the drug, and you might lose the patient as well. So what is the mechanism of action of colistin and polymyxin B, right? So this is a schematic for the same. There is colistin and polymyxin B are positively charged molecules, whereas the gram-negative cell wall is a negatively charged, has a negatively charged surface. So the opposites will attract, and the protons of colistin will go in, and in compensation, the calcium and magnesium of the gram-negative cells will start going out. So this way there is a cell death because this is structurally not good for the bacterial cell. So they act at the level of the cell membrane, right? Not at the cell wall level. They are bactericidal, and this is their mechanism of action. So now just a small graph to show you the various locations and mechanisms of action. So the beta-lactams, they act on the cell wall, and the polymyxins, they act at the cell membrane level. And there has been in vitro synergy observed between meropenem and polymyxins and imipenem and polymyxins, which makes logical sense because the beta-lactams, they inhibit the cell wall synthesis, which may allow the polymyxins to penetrate better towards the cell membrane. Now, there's another drug which has been shown to have in vitro synergy with polymyxins, which is fosfomycin. Now, fosfomycin acts at a level even before the beta-lactams. It basically inhibits the formation of the precursors which are used to form the cell wall. Right? So, fosfomycin also logically will have a synergy with polymyxin, which we can understand from this diagram. Okay. So all this will come in important later on. So just try to keep it in mind. So now we come to a case, right? So it was a 55-year-old male presented with fever with chills and left flank pain. Imaging showed, strangely a right moderate hydronephrosis. I've seen that sometimes we don't know why that happens. In pathology is on the right side and the patient comes with a left side pain. And the urine culture grew a carba-resistant pseudomonas, and he was treated with a meropenem and polymyxin B. Okay, so now I cannot make it very interactive and see your answers, but try to analyze and think what must have happened. Why is the drug not? Why are the drugs not working? So basically, the patient was very slow to respond and did not respond fully. So what do you think would be the reason for that? Now, he also underwent a urologic procedure with a stenting, so source control was also done. Despite that, he did not improve as much as we would expect. So, have you thought of what your answer should be? So, I will go ahead. Huh? So, PKPD and penetration. So, the answer is PKPD and penetration. We have to always keep in mind where our drugs are going and where they are not going. Right? So this person was receiving meropenem and polymyxin B for a UTI. Right? Now, the important fact here is that polymyxin has uh, very poor urinary penetration. So if we need to use a polymyxin for a UTI, we must prefer colistin in most situations, especially lower UTIs. In sometimes in pyelonephritis, you may kind of get away with the polymyxin B because the parenchymal levels are not so bad, but still we must prefer the colistin because it is the only one which goes below into the kidneys and into the rest, urinary tract below the kidneys. So for lower urinary infections, never ever forget you can't give polymyxin, you must give colistin. So what are the differences between colistin and polymyxin? One difference we already learned now through the case, right? So colistin is available, systemic colistin is available as a prodrug by the name of CMS, that is colistimethane sulfate. And it is converted to colistin by hydrolyzation. But this conversion to colistin, which is the active drug, is a variable and slow and often incomplete process, which may take up to 7 hours. So we don't know when it will happen, the conversion. We don't know if the full conversion will happen, and we know that it will take time. Right? So this is one of the problems with colistin. It is a prodrug. It is not the active drug when we give it IV. Right? When compared to that, polymyxin is better in that sense. It is the active drug, although the loading dose is still needed, but it is the active form of the drug which is being instilled IV. And that doesn't need conversion, and that conversion, if it's not there, of course, it will not be variable and incomplete and all those things, right? So onset of action will generally be quicker with the polymyxin. because it is an active drug. Again, this point comes in very important in one of the later cases. Please keep it in mind. Now, colistin penetrates into urine and it is useful in all urinary infections. Polymyxin does not penetrate into urine and is not useful, especially in lower UTIs. Colistin, again, very logically, if it goes into urine, it will have more nephrotoxicity, right? So it is more nephrotoxic than polymyxin. This has been proven in many trials. It occurs earlier by the fourth day of treatment, and it occurs in almost in some studies 50 to 60% of the patients. Polymyxin B is less nephrotoxic, less nephrotoxic, and this toxicity also occurs later in by the seventh or eighth day, by which time many times our patients are better, and it can affect up to 40% of the patients, right? Now, in PKPD, we always want to reach certain levels of the drug. And those drug levels have been shown in many trials to have successful outcome. And those drug levels attained and the successful outcomes attained then determine the breakpoints for the bugs for those infections based on the clinical trial data, right? So the breakpoints are consistently updated and modified by the standard organizations like CLSI and UCAST, right? But that breakpoint determination is done by what blood levels were reached, how much was the success rate at what blood level, those kind of things, right? Now, in the trials, we also study how often the drug reaches that desired drug level, right? Is it easy? Is it tough? How many patients, how many healthy volunteers, and how many patients end up reaching that target drug level when we give these drugs, right? So this is one big problem with colistin is that the target attainment of the drug level is poor, especially if the creatinine is normal or there is a augmented renal clearance in the septic patient, right? So in that case, the colistin doesn't reach good levels and the probability of target attainment is low. Whereas in the polymyxin, this is not the case. Probability of target attainment is higher. One, because it is an active drug and it has lesser risk of poor conversion to activity, and it has more predictable protein binding and therefore less variable drug levels. Whereas in colistin, there is a variable protein binding in different individuals leading to variable drug levels. So dose adjustment is needed in renal failure for colistin, whereas it is not needed in polymyxin. This is a very common misconception and people keep doing it, and which is not good for our patients. It is clearly recommended. There is enough data now showing that polymyxin B needs no dose adjustment in renal failure. If your patient is developing renal failure while on polymyxin, continue the same doses. Huh? And if it is getting too severe and you need to change it, then you need to just change it or stop it or give something else. But adjusting the dose is not really going to help. And infection wise also, it's not going to work if you lower the dose, right? Now, coming to the last point, colistin is gentler on the meninges. That is why it is preferred in the intrathecal and inhalational therapy over polymyxin. Huh? Polymyxin is more neurotoxic, so more risk with intrathecal administration. But again, in certain rare situations, you may need to give the polymyxin instead of the colistin intrathecally, and we'll come to that, right? So I hope everyone has understood this table. This is actually the heart of the topic. This table you need to understand very well, and it will be very helpful in your individual private practice, right? Just to summarize, colistin is a prodrug. Drug levels are variable. Target attainment is poor. It is more nephrotoxic. Dose adjustments needed, and it is gentler on the meninges. Polymixin is an active drug. Loading dose is needed. Doesn't penetrate urine. Less nephrotoxic. Probability of target attainment is high. And there is a more predictable protein binding. Dose adjustment not needed. And try to avoid it in intrathecal administration. Right? So for UTIs, the answer to the previous case, for a urinary tract infection, always try to use a colistin. And for most other indications, polymyxin will be preferred because it has PK/PD superiority, right? In most other situations, as long as the patient is tolerating it, then polymyxin B is the preferred drug, right? So this was a case, another case. We'll come to another case. So everybody can wake up now. It's a very interesting case. So this was a 55-year-old guy, a businessman by profession, was diagnosed with HIV-2 in 1997, at which time he took ART for 1 year and then stopped on his own. Now, almost 20 years later, he came with a left neck swelling and low-grade fever since 1 month. Now you can see it on the image here. It's a big node, right? And there's a PET scan image as well, right? So this was biopsied. The neck lesion was biopsied, which turned out to be diffuse large B-cell lymphoma. And a large liver lesion was also observed. So now his CD4 was 354, which is not too bad, huh? But lymphomas can occur at any CD4. So he was started on a regimen of dolutegravir, lamivudine, and tenofovir. Protease inhibitors were avoided in view of interactions with the chemotherapy. NNRTI was not an option as this patient had HIV-2. So NNRTIs don't work against HIV-2. He then received chemotherapy with DA-EPOC. Please don't ask me the full form. Following this, he came with altered sensorium and high-grade fever for 3 days and was found to be hypotensive. And he was intubated and treated as a neutropenic sepsis and started on empiric meropenem. The repeat imaging was done to look for the source of the sepsis. So remember, he had a big liver lesion and that neck lesion, which were nodes, and the liver lesion was probably part of the lymphoma. Now, what happened is that the radiologist is not aware of the history, and they are seeing him, or they are seeing this image without really comparing it to the previous. So what he has reported is that there is a hypodense lesion in the liver, and it shows thick peripheral enhancement and with increased inflammatory changes. And they called it as a abscess in the impression, right? But if you see, clearly, this liver lesion seems to be much bigger on this image, and this is much smaller, right? So, we thought it is more likely that after chemo and that lesion has shrunken, then it is less likely to be infection, more likely to be part of the lymphoma, right? So we were not convinced that the liver is the source of the infection, right? So now what happened is that in a blood culture, we grew a yeast, which is shown, which is a Candida tropicalis, which was a pan-susceptible. But I want you all to pay attention to this investigation chart that has been noted on the indoor notes, right? So as you can see from 3rd of July to 18th of July, serial CBCs have been noted and the creatinine has been noted. So his chemo was received somewhere between the 3rd and 15th of July, and you can see a drastic drop in the WBC count from 15th onwards, right? Which is expected after chemo. Platelets have also had a drastic drop, which is also expected. But can you see that the last line, that is the creatinine, right? Can you see what is happening to the creatinine? Right? So, as you can see, it's been steadily dropping. So what do you think is happening here? Why is the creatinine dropping? We all know why the creatinine rises. But do we know why the creatinine is falling and why it falls? And why did it fall in this patient? And it's a very significant fall, right? 1.7 to 0.7. So we have to kind of go back to our first year physiology and understand this, because again, it's a very important point for ICU, is that, see, um, creatinine is a product of muscles, right? So one reason for a low creatinine or a dropping creatinine can be a loss of muscle mass. But this is too rapid a fall. 3 days for it to be such a sudden, muscle loss. Right? Now, what else happens? What other physiology is there in the creatinine? So again, now you have to realize that creatinine is a product of the urea cycle. Now, part of the urea cycle happens in the liver, right? So if there is a liver dysfunction, which is an early liver dysfunction, which has not been complicated by the hepatorenal syndrome, but a severe acute liver dysfunction can often cause a reduced formation of creatinine via the urea cycle because the liver is not working. So acute severe hepatitis is one of the causes for a falling creatinine. Now this was again possible in this patient, but less likely as the LFTs were not that bad. Now we come to the third reason, which is most important for you guys, that in severe neutropenic sepsis, right, there is a hyperdynamic circulation. So there is increased blood flow to the kidney and there is increased rate of glomerular filtration, right? So the filtration of the creatinine increases and basically there is a hyperfunctioning of the kidney early in the sepsis, which you call as a augmented renal clearance, right? So in these type of charts, you have to notice and you have to be very careful about your antibiotic dosing, and we should try to give the maximal possible doses, right? I wanted you to notice this augmented renal clearance, which is happening in this neutropenic sepsis patient. Now, the ideal way to measure this renal clearance, augmented renal clearance, is by doing a true measurement. So you keep doing urine volume and urine creatinine, and there are those calculations available which the nephrologists know, by which you measure the creatinine clearance. You don't infer it by the GFR or the creatinine. But that can be very tedious to do, and this can be a simple bedside clue you can pick up. That a falling creatinine can mean that there is a augmented renal clearance. In that case, you want to give the maximum possible doses. His eGFR came out to be about 130 ml per minute. Hence, the dose of meropenem was increased to 2 gram TDS. Right? So, this is how PKPD can help you leverage better outcomes for your patients. Right? So, now anidula fungin was changed to fluconazole and he was extubated and he improved and he was discharged. But this was after his first chemo. He came back for his second chemo, but then went into another sepsis and he succumbed. Now, there is no polymixin in this whole case. So, why did I tell you? Why I told you is that when this happens, uh, there is a very big risk of colistin failing. Not because the bug was resistant, but because we fail to attain good levels in this kind of situation. In a patient with normal creatinine or an reducing creatinine indicating increased renal function, we really struggle to achieve good drug levels. So we may need to give higher doses. And if it is not a UTI, we may need to give polymixin and even polymixin at higher than normal doses. Now, there are lots of studies which have been done to find the ideal dose of these drugs. It's an evolving field, so I've not mentioned many of those studies, but do check out these two authors. They have authored many papers on the dosing of polymyxins. One is Roger Nation, lot of publications on polymyxins. Second is one guy called M. Falagas. And third is one Indian guy who's doing brilliant work in this field. He's very interested in PKPD. He works in Dinanath Mangeshkar Hospital, Pune, Mr. Dr. Parikshit Prayag. So Parikshit Prayag, there are a lot of lectures of his also on YouTube. If you are interested in infectious diseases, he's a brilliant, brilliant guy to hear. Right? So he has done actual PKPD studies of polymyxins in his hospital. The data has not been published yet, but I heard him at a conference in which he mentioned that even with polymyxin B, there was very bad overall target attainment, but it was significantly better than what we achieved with the colistin. Okay. So now just a small bit on augmented renal clearance. Critically ill patients in sepsis can have an augmented renal clearance, and doses should be adjusted as per measured or estimated GFR. Most authorities recommend a measured GFR, and these are the legends in this field, which is augmented renal clearance, unraveling the mystery of elevated antibiotic clearance. And there are two papers, a comparison of estimates of GFR in critically ill patients with augmented renal clearance. Now, we'll go to the next case, right? Now comes the important part about antibiotic brachytherapy. Now, why we call this as antibiotic brachytherapy? Because we are trying to use high local concentrations in order to overcome the problems with the systemic therapy not reaching the site of infection, right? So we do this in the meninges with intrathecal antibiotics, with intrathecal colistin and polymyxin. We do this in the ear, carba-resistant gram-negatives or carba-resistant pseudomonas with otitis externa and otitis media. We can use the neomycin drops, which can achieve enough local concentrations to overcome the resistance, right? And then there is also rarely what we use as an intravesical bladder therapy for UTIs, lower UTIs, in which we want to avoid the systemic therapy for some reason. And it's also there is a use in the antibiotic lock therapy when we try to preserve the perma catheter or the temporary HD catheters in the ill patients who are not suited for a change of the catheter. So the principle here is that if you go 1000 times above the MIC concentration, then the resistance is overwhelmed many times. Even if you have R in the report, if your local concentrations are higher, 1000 times higher than the MIC, then you can overcome the resistance and the local therapy will still work well. So based on this principle, when I was training in Hinduja Hospital, my mentor, Dr. Rajiv Soman, he had composed a lot of antibiotic locks based on the MICs. And we used it in many situations where the change of the line was not possible or very difficult. And we had very good results. So I will show you the paper and the calculation behind how we did it, right? So just as an example, this is a catheter collection which has grown carba-resistant Klebsiella, and the colistin MIC is 0.5. This would be called intermediate by the CLSI right now. This is an old patient with an old antibiotic report. That's why it's been reported as susceptible. So now we want to go we want to go 1000 times the MIC, right? Now the MIC is 0.5, right? So 1000 times the MIC, and this is microgram per ml, right? So we want to go 1000 times of that, which means we want to go 500 micrograms per ml. So which means we want to go 0.5 milligrams per ml, right? So if we achieve 0.5 milligram per ml in our local therapy, either in the lock or other way, then we can achieve excellent levels at the site and which will have a higher chance of success locally. So 1 vial of colistin will have 80 mg of colistin. We reconstitute it with 8 ml, so that gives you 1 ml equals to 10 mg. Okay. Now, if the volume of the catheter is 2.5 ml and the total colistin we need is 2.5, because suppose, 0.5, right? And kind of, uh, maybe I did a mistake in the calculation here, but based on this, suppose we have 0.5 milligram per ml and multiply by 3 to give you 3 ml, how much you need total in 3 ml, right? With that, you get this number, you get some number, and then you can take 0.25 ml of that to get that number, and you add in mucomix, NS, and heparin to make a 2.5 ml of total solution, right? And we insert this solution into the catheter post HD and we keep it unchanged for 24 hours, right? I'm sorry about this miscalculation. I think there is a miscalculation here, but you get the concept that we want to reach 0.5 milligram per ml of concentration, and we can multiply by the volume of the catheter to see how much total milligrams we need to reach. And then according to that, that much ml we can take of this solution. Okay, and then remaining part, suppose we are taking only 0.5 ml or 0.75 ml of that colistin solution, the volume of the catheter is 2.5 ml. The remaining volume we can put in other biofilm active agents like mucomix and heparin, and we can just dilute with normal saline. The whole concept is that we want to fill the catheter with that locked solution, but we don't want to put that locked solution into the intravenous system, right? So they will have an action in the intraluminal part of the catheter. So intraluminal types of CRBSI, we can try to salvage the catheter. This high concentration kept for 24 hours was found to be effective. It's not that we have done this first. There have been many papers abroad which have done it. We have used our methodology and some of their recommendations to compose our locks. So this was the paper that we presented in the JAPI journal. You can see Dr. Rajiv Soman, antibiotic lock therapy in the era of gram-negative resistance. And we just look, there was a significant number of patients, over 1 to 2 years of data. And you can just look at this line. Successful treatment with antibiotic lock therapy was observed in 81% of the 37 episodes. So in 37 episodes of CRBSI, 80% of the time we were able to salvage the line with antibiotic lock therapy, which uses this concept. Okay. Now, I will tell you a little bit more about this in a little while, right? Um, so this was yes, this was actually a case I presented last time as well. Huh? So I don't want to, in the fosfomycin presentation, I had presented this case, but basically it's a repeat. So I'll just go through it more quickly. Right here, we used polymyxin along with colistin in order to save the kidney. We didn't want to use full doses of the colistin, right? Uh, you can go back to my previous video. I've explained in that as well, right? So now we come to the contraindications to log therapy. So you can't use log therapy, antibiotic log therapy in every patient because it will not work. And it is very dangerous to use it in some of the patients. In most, in many of the patients, we have no choice. We must remove that line, especially if we are sure it is badly infected. So in severe sepsis with septic shock, we need to remove. In metastatic sites of infection, we need to remove. Visible pus outside the catheter lumen, we need to remove. Okay. Only in intraluminal and milder cases of CRBSI should you try to use this antibiotic log therapy. So based on some of the earlier data that was there in this field and based on the MIC calculations, this way we had composed several gram-positive and gram-negative locks, and this is the composition of that, right? This is not a standard guideline. This is just what practically we had done. So you can see it's a similar theme. We found out what is the antibiotic concentration recommended in the log. How could we compose it with the vials that we had? And after composing the desired concentration, we diluted with mucomix, NS, and heparin, right? So like that, we had composed some antifungal locks as well for fungal catheter infections, right? So now we come to the last case, probably the last case, and some further fine tuning of some of the points. So this was an elderly diabetic, hypertensive since 15 years, uh, prostatic hyperplasia since 2 years. He underwent a CABG for ischemic heart disease. 20 days later, he presented with mild burning micturition and a low-grade intermittent fever, which was lasting for 20 days. Sorry, 10 days. And the urine showed a lot of pyuria and the culture showed CRE, Klebsiella susceptibility only to colistin. Now, this is again an old case. We didn't have Ceftazidime-Avibactam at that time, but it is an interesting phenomenon. I wanted to show you what happened with him. So in this case, we had to give colistin and let's see what happened. So he received that loading dose of colistin and he had significant giddiness during the infusion, right? And his creatinine, which was baseline of around 1.4, 1.6, it had shot up to 3 by the next day and it continued to rise to a peak of 9.1 in 5 days. So this was a very, very bad experience that we had with colistin, but it is important to note that this was actually not the usual nephrotoxicity we see with colistin. We don't see such a bad one. We see a gradual ATN type picture. This was actually more of a AIN, acute interstitial nephritis, because this is a test I have seen only positive only once in my life. So we sent a urine eosinophils to check whether it was a AIN, and that came positive. It was actually 7%. 7% eosinophils were seen in the urine. So this was a confirmed case of colistin-related acute interstitial nephritis. So we could give steroids for him and he gradually improved. Another finer point here was that then we gave fosfomycin instead, and that fosfomycin selected out Morganella. Right? So CMS-induced nephrotoxicity is mostly mild and reversible. Renal replacement therapy is occasionally required. Permanent damage is rare. Kidney injury was found to be related to the total cumulative dose and the duration of CMS therapy. This is in the usual situation. This patient, it was a idiosyncratic AIN. Okay. So, mechanism of nephrotoxicity is by an increase in tubular uh, epithelial cell membrane permeability. There are also some oxidative inflammatory pathways. Morganella is one of the organisms that are resistant to colistin, hence it was selected out. Now, this is what we use for local therapy in the ear. There are similar kind of things available for the eyes, right? Here we try to use in otitis externa, which is carbapenem-resistant Pseudomonas otitis externa. We can use, unfortunately, it is available only as a pair with hydrocort, but on balance, it seems that we must use it sometimes, right? Now, this was what I was mentioning about the intravesical colistin for Pseudomonas and other urinary infections. These are the references for the same. So this kind of thing, basically patient is having carba-resistant bug in the urine and systemic symptoms are not very severe, but we need to decolonize the bladder either for a urologic procedure or for other reasons, right? So in that case, we can avoid the systemic therapy and give a directly bladder therapy with a colistin for a decolonization of the patient's bladder. Of course, we must make sure that we are not treating a colonizer from the catheter because urine culture in a chronically catheterized patient will also often have a colonization and biofilm formation, which will not represent the flora in the urinary bladder. In that situation, we generally recommend that if there is a confusion, we should replace the catheter and the urine culture should be sent from the freshly inserted catheter, which will be representative of the flora in the urinary bladder rather than the biofilm outside, right? Once you have a confirmation of a CRE bug and you want to decolonize for some reason, then we can use a intravesical colistin. So this is what I composed of my own based on these 2, 3 case series and case reports. So this seemed the best thing for us to do. So you can take this method, you can use it. You can take 1 MIU in 10 ml of NS, which will be 1 ml from that will be equal to 1 lakh units, which we dilute further in 50 ml NS, and we instill it in the bladder through the Y node, and we clamp it because we want it to stay inside with a dwell time of 60 minutes. Then we release. We can do this 2 to 3 times a day for an intravesical local colistin therapy for lower UTIs. It will not help in a pyelonephritis. Okay. So finally, I think it's one more last case, and then we'll stop. So this was a 45-year-old male with SAH and EVD in situ who developed carba-resistant acinato meningitis. Due to issues with the ICP, the EVD could not be clamped for more than 1 to 2 hours. Right? Now we need marrow colistin IV and we need the intrathecal colistin. But now the intrathecal colistin is staying only for 1 to 2 hours. Right? Otherwise, after that, the clamp is being released. So now the patient is not responding. What do you want to do? You're already on maximal therapy. No other drugs are sensitive. What else can we do? Think. So the answer here is that we are having an inadequate dwell time, an inadequate duration of the local therapy because we need to declamp the EVD. And colistin is a prodrug. We learned that in our theory. So can we shift to intrathecal polymyxin? Because it is an active drug, it is more likely to work in that window that we have 1 to 2 hour window only. It is more likely to act than the colistin, right? So that's what we did. This was actually a case of ours. I don't have the images with me, but we did it and there was a decent response after we changed to the polymyxin active drug in this situation with a systemic and an intrathecal polymyxin. Sorry, systemic and intrathecal polymyxin. So PKPD, poly B is active drug. Yes, yes. Yeah, insufficient dwell time was the issue. So with that, we for that renal clearance. So that's what ideally should be done till you get used to the dosing.
Okay, sir. Then about the infusion volume, sir. Polymixin B has a lot of infusion volume, I think, right? It has to be given in 500 ml, so that becomes a problem sometimes when it's a BD dose. So, is there anything about, you can tell us about that, sir? Because that is 1 liter of infusion, fluid infusion.
Correct. So many of the references have given that we need to give polymixin B slowly and over 2 hours in a 500 ml of D5 or NAS, right? But we did further research on that and we found that it's actually fine. We can give it in 250 ml also, and in a desperate situation we can give it in 100 ml also. But we do need to give it slowly because it is an active drug. So infusion ke saath saath tingling of the mouth, neuromuscular weakness, all these things, infusional toxicity is more with the polymyxin and not so much with the colistin. So we need to give the polymyxin infusion, even if we don't dilute it too much, we need to give it slowly over 1.5 to 2 hours. So that helps with that in reducing that infusional toxicity.
So talking about the neurotoxicity, what kind of worst neurotoxicity have you seen, sir, with the polymyxins?
I've seen, sir, 2 cases developing very bad neuromuscular weakness, right? One patient just recently only, actually, he was given polymyxin by other person, not by me. but he almost developed like a bulbar palsy and he was intubated. So he had fluid overload, CKD, many other things. But this bulbar palsy, which was probably caused by the polymyxin, landed up with the intubation. So that is definitely a risk. So we should never use it unnecessarily. But also keep in mind that if that neuromuscular weakness is too severe, then you may be dealing with the unmasking of a myasthenia or a Eaton-Lambert syndrome because they are neuromuscular toxicity. If the patient has an underlying myasthenia which was prior undiagnosed, then that may get unmasked and you may be able to diagnose it now with either a RNS stimulation test or a ACRA antibody and anti-mask antibody and all those things. So in this recent patient, which I said developed a bulbar palsy, we have sent it. Primary has not gotten back to me yet, but he's improved dramatically after we stopped the polymyxin, got extubated. Most likely he will not have it, but we've sent it in him. Workup for myasthenia. Yes.
Is there any role of giving calcium in these cases of neuromuscular toxicity? Does it help to reverse or something? No, I read
Mm,
something like this somewhere.
not very sure, huh, sir?
Okay.
Not sure.
Okay.
Maybe I read a case report some years back, but I can't place it. I can't
Okay.
remember.
Just final points, sir. There are no questions from the audience. You said about colistin not being very effective if there is augmented renal clearance or the creatinine is normal. So can you just
Yes,
explain that again to the audience, sir? Because that is a good point, I think.
correct, correct. So see, basically, colistin pharmacokinetics are very variable, and it is rather unfortunate and paradoxical that if there is a renal failure, then the colistin doesn't get excreted so much, right? So then the target attainment of the drug which we need, the steady state of the drug which we need, is easier to attain in patients with renal failure. In patients with normal creatinine, we really struggle to reach the blood levels of colistin in many of the patients. And this has been seen in many studies reported by Roger Nation as well as Parikshit in his study. Um, so we need to give higher doses and at least full doses. I see a lot of misdosing of colistin and all that. So in that case, then despite colistin being sensitive, it will not work because we are just not achieving enough levels in the body.
Okay, sir. So I think there are no questions. That was very nice, sir. Very nice presentation, and you explained very nicely. So there on our YouTube channel in a week or so. So thank you so much, Dr. Kanishka, sir. See you again sometime. Take care. Bye bye. Thanks the
Thank you.
audience for
Thank
their
you. Thank you,
wonderful
audience.
patience. Thank you, sir.
Thank you. Thank you.